All right, Craig and Phil here, part of your Sugar Creek education team, with a quick review of the use of CPAP on an ambulance. Go ahead, Phil.
All right, so CPAP is important for your severe respiratory distress patients, especially those that have pulmonary edema, which we'll talk about. It's a closed system, latex-free, which can be used for pulmonary edema, which is a lot of fluid buildup on the lungs. They usually cough up pink, frothy stuff. They sound really wet. This will push air in there, give them a lot of pressure to move that out of the way so that you can oxygenate the patient a lot better than just with a non-rebreather or nasal cannula. It has safety features like a manometer, which we'll talk about when we show you the device. Pressure relief valve, titratable pressures with the change in oxygen. It's portable, easy to set up, really quick to use, and if you can get the patient to take it, it works really well. So you want to make sure that this CPAP that you have has those safety features and it's not an older model that doesn't have the manometer and other parts. So what you are going to use CPAP for is the patient needs to be in respiratory distress, severe respiratory distress. They need to be awake, able to follow commands, able to cooperate. They need to keep an open airway, have a GCS greater than 10. If you don't know what GCS is, look up the Glasgow Coma Scale and learn what it is. They need to be having retractions on a, which is like belly breathing, and you can see the ribs. Accessory muscle use during inspiration, which is like belly breathing and chest, using a lot of doing a lot of that. Respiratory rate greater than 25. An oxygen level less than 94% at any time on room air, not with a non-rebreather, on room air. And then a systolic blood pressure, so you need to get a full set of vitals of greater than 100. And we will talk about that later, of why that happens. What you cannot use CPAP on is anyone less than 16 years of age. If they cannot follow commands, have a GCS less than 10. It is not mechanical ventilation, so if you are bagging the patient, this is not to replace that bag. That is totally separate. If they are apneic or not breathing, CPAP does not work. The patient needs to be breathing, hence the able to follow commands and the GCS greater than 10. If they are hypotensive, so what it does is it puts more pressure on the chest, and it can cause your blood pressure to go down. If they are unable to handle it, if they are anxious, which most of these people that can't breathe are going to be anxious, but the psychological effects is that they just panic and are claustrophobic usually. If they maybe have a pneumothorax, which is air around the lungs, usually from a severe trauma like a fall or a car accident, that is why they're getting short of breath. And it can cause drying of your eyes, which is just one of the side effects of it, because it's putting a lot of air, and when you breathe out, it kind of leaks, especially around the nose, and it causes some drying of your eyes, which is fine. Non-respiratory arrest or apneic, patient has agonal respirations, needs intubation. We kind of talked about this in the last slide, a lot of these things. Penetrating chest trauma, cannot use. There's hence the pneumothorax or hemothorax. You can't use it for those kind of things. Just talked about the pneumothorax. Patient has a trach, can't use it for that, not going to do any good. They complain of nausea or vomiting. That's a risk of aspiration. If they were to vomit, you're just going to shove all of that right back down their throat and potentially into their lungs. Or they have a GI bleed or recent gastric surgery that goes to that pressure of the abdomen that it can cause. And upper GI bleeding, they are at risk of vomiting up the blood. So you can't use it for that. So the reasons why you might want to use CPAP is pulmonary edema, like you talked about in the first slide, of that fluid that's built up in your lungs. CHF, which is usually resulting in the pulmonary edema, they usually have CHF as well. COPD is a really good one for patients that are on oxygen a lot of times, and they kind of have more inflammation that's causing the shortness of breath. This will help open things up if they really have a lot of obstruction with the COPD. Asthma is really good when they have the constriction of things as well, and they're wheezing a lot. And then pneumonia is just helps they have infection in their lungs, inflammation in the lungs, and you can use it for that. But you won't be able, these are all diagnoses that you won't be able to do. You have to go based on the signs and symptoms. But these are a lot of illnesses that can cause you to use it. They need to be on pulse ox or capnography, preferably pulse ox in this case, because the capnography is really inaccurate because it's not getting your CO2 because there's so much oxygen around that device to measure it. It's really inaccurate and you can't really measure the CO2. So pulse oximetry. If they have a history of chest trauma, if they're in a trauma, car accident, or fall, something like that, then don't use the CPAP. If you really think you can use it, call medical control, defer to ALS. And then you need to have signs and symptoms of pneumothorax. Listen to the lungs, make sure they have lung sounds on both sides. That would be a sign or symptom of pneumothorax if you don't hear things on one side. They need to be in respiratory distress. They'll have decreased or absent breath sounds for the pneumothorax. They'll have a distended neck veins. You'll see jugular vein distension. You might see some low blood pressure, and then tracheal deviation. So if they have a distended vein, you'll see some tracheal deviation. So the trachea will be kind of pushed one way to the opposite side of the pneumothorax. So to use this, place the patient in a sitting position, preferably like a straight up. These people are not going to want to be laying down at any angle. They're going to be straight up. You'll usually see them in a tripod position, which is like they're sitting down, their arms are on their knees, they're hunched over. That's a good sign that CPAP is very likely to be needed for this patient. That you need to ensure you have a good oxygen supply. The little tanks you take into the house are only going to last about 10 minutes or so on the high flow, so make sure it's a full tank, that you're going to have enough to get the patient out of the house. You don't want it to stop halfway through. To have the full set of vitals, like I said, you want to know their blood pressure before you start it, and then communicate with your patient. You need to have good communication skills. You need to talk them through it. You need to tell them that you're going to feel pressure on their face, that they need to try to breathe through it, slow their breathing, and just concentrate on that, and it will eventually, in a few minutes, it's not getting instant relief, but in about 10 minutes or so, they should feel much better with this on. In through your nose, out through your mouth. Place it over the nose and mouth, and we'll show you kind of how to do that. You can have the patient hold it there. Don't strap this thing around their head and then place this over there, like slip it down over their head. Just hold it over their face. Let the patient have some control over it. Go slow and allow them to have some input on how this is going, and that it'll help relax them and give them something to kind of work on. After you kind of place it on there and you kind of talk them through it, and they're holding it on, you can put the straps around their head and secure it. And then if you feel like it's CHF, if they have a lot of pink frothy sputum, they sound really wet and full of fluid, you want to kind of titrate this mask up to the 10 mark. You're always going to want it 5 to 10 for every patient, but preferably for this, those kind of patients you want it at 10. And then check for air leaks, adjust the mask. It's got adjustable straps and Velcro for it. So I think we're going to talk about that next. So here is your CPAP. That's going to be in this kit. You're going to have a large and a small. Most patients, you're going to use the small. Usually start at the small and go up if you need to, versus play around with the large one for a long time trying to seal the leaks. Usually start with the small and kind of go up. And if you want to, you can kind of hold this up against their face and kind of see, does it go over their nose? Does it go down too far over their chin to know kind of which way? But like I said, usually it's safe to say start with the small. So here is the open version. It's got a nice net kind of behind it for the straps. Here is your manometer, which is your guide to what you want. So you want it at 5 to 10 is where you want this little dial to be set in it, and the 10 is for like your congestive heart failure patients or your flash pulmonary edema patients. Here's your pressure relief valve, and then here is a nose piece that adjusts too, so that it kind of adjusts their face. If it's down a lot of the way, it's going to really pull this in towards their face. If it's up more, it's going to push that nose a little further away. So if you have a lot of leaking up into their eyes, you can kind of adjust this down, and it might give you a lot of help. So like I said, you're going to hold this up against the patient first, over the root to the nose, down over the chin. You should get a really good seal. You kind of have to give some force to push it behind it. Let the patient kind of work with you on doing that. You're going to put the net around their head. One side is going to click. It clasps right there. The other side is also going to click. This one's really tight. And it's got Velcro at the top where you can adjust it, and it's also got Velcro on the sides so you can make it tighter or looser. Usually it starts out pretty loose and you'll have to tighten it up. And like I said, this nose piece, as you can see, it really loosened it up on the front of their nose, so it's really loose there. And if I bring this back down, it's a lot tighter. I'm pulling the whole head now because of that. So,
and this one here is really too big for her.
Yeah.
Those pads on the top should really be against her forehead.
Correct. But this is really loose now, and if you tighten it up, now it really pulls it up to the face. But yes, this should be more down here on her head, like that, and kind of give some.
And then show them how those straps do adjust on the sides there.
But yeah, there's Velcro. That's all the way back. So there's Velcro is kind of pull. It is elasticy, and you can kind of secure it. And you'll want this plugged into the oxygen, but for this purpose, we don't have a lot of oxygen. So plug it in before you place it on the patient and make sure that they have a good seal.
Right. So again, we're going to have the oxygen flowing through this as they bring it and hold it up to their own face.
And you can adjust it for the straps when you strap it on to make for the leaks that you have and make it a little bit tighter. So you'll crank the oxygen all the way up on this tubing. It has a good guide to what flow potentially will get you the pressure that you want. So it says flow 8 to 9 is going to get you about a 5. 10 to 12 is going to get you 7.5. 13 to 14 is going to get you 10, and then 15 and above. I usually just crank it all the way up to 15 to start out with, and then you can see the manometer. So that was 10, it was only at 5. This is 15, it is at right where you want it, 7.5. And you're going to see that thing fluctuate. As the patient breathes, when they breathe in, it's going to go down. As they breathe out, it's going to go up. You want to always keep it in that 5 to 10 range. And transport the patient. If you are using this, you probably need to call ALS just because the patient is in that severe of distress that they need that they potentially could wear out and stop breathing altogether and may need more interventions. So if the patient's bad enough to need this, you need to have ALS involved. And that's kind of the CPAP for you.
Okay, so as with anything else, if you have more questions about CPAP, make sure you reach out to Craig or Phil or anybody on the education team, or talk to Jim in the office, and we'll all help you out. Thanks.